totally shifting gears, the patient that could potentially have a resection. Okay, so when you see a patient, Caio, initial diagnosis of pancreas cancer, looks like it might be localized to the pancreas. What do you do?
First thing I do is to review the films with a good radiologist and make sure that the CT scan is up to standard. And the pancreatic protocol CT scan with thin cuts through the pancreatic bed is paramount, because the resectability is based on a relationship of the tumor with the surrounding blood vessels. We're talking about the superior mesenteric artery, the hepatic artery portal vein, and so forth. So having a good arterial phase and venous phase with thin cuts CAT scan is very important. Having that separated between patients that are borderline resectable is also very important to patients that are clearly unresectable. The regimens we have today give us the opportunity, because of higher response rates, to have in mind and give the patient the hope that the borderline resectable patients can actually get to a higher resectability rate by being treated with systemic chemotherapy first. The trials are still lacking. Unfortunately, we're using common sense. We are using a leap of faith based on the phase 3 data, using response rates from phase 3 trials done in metastatic disease and importing them in the locally advanced disease in borderline resectable patients. Measuring response is very difficult in patients with borderline and locally advanced disease, but having the good quality scans before and after the treatment can really aid in having the patient a higher chance for resectability. So based on the response rates, with FOLFIRINOX compared to gemcitabine, and with gem/nab-paclitaxel compared to gemcitabine in 2 phase 3 trials in metastatic disease, we feel that this is the way to go in patients with locally advanced disease. But clinical trials are coming, and we're going to have these answers based in phase 3 data.
So if a patient appears initially resectable, straight to the operating room, or do you give them some treatment beforehand?
Yeah, we had a wonderful discussion this morning. I hope everybody in this panel had an opportunity to attend the view from the medical oncologist and the view from the surgeon. We've been through 30 years history. If you take the initial trial of radiation or 5-FU radiation in the adjuvant setting after resection, the intergroup trial that took 8 years to complete, showing that 5-FU in radiation was better than radiation therapy alone. Keeping in mind that we believe that radiation may have been placebo in the entire story. So 5-FU has been established in the adjuvant setting since then. And the CONCO trials came along, and we still found out that the efficacy of gemcitabine is the same as 5-FU in the adjuvant setting. So progress has not been made for many years. We know that there is a small benefit in the adjuvant setting, but we haven't had a new adjuvant trial done to date to tell us if this strategy is advantageous compared to adjuvant treatment. Having said that, it's so appealing. The high chance of tumor relapse, only 1 in 5 patients will be alive in 5 years if you take all comers with R0 resections. And these patients fail very often right away after surgery, telling us that at least the new adjuvant approach could aid in telling us the biology of the disease, taking away unnecessary surgery in patient that has rapidly progressing disease that will fail right after a WIPO or distal pancreatectomy.